Good afternoon and welcome to today's complimentary webinar. Thank you for your patience as we overcome some IT difficulties. Today's webinar is on medical respite, including what it means for the Illinois Medicaid program, presented by the Illinois Public Health Institute, the National Healthcare for the Homeless Council, the Illinois Department of Human Services, and the Illinois Department of Healthcare and Family Services. My name is Jill Hayden. I'm the CEO of the Illinois Association of Medicaid Health Plans, also known as IMHIP, and I will be moderating today's webinar. As the member organization for the Medicaid Managed Care Health Plans, IMHIP works with Illinois state government, legislators, advocacy groups, and Medicaid providers and members to invest in and provide high-quality healthcare focused on cost-effective, individualized care that helps the residents of Illinois live longer and healthier lives. Improving healthcare delivery systems is a never-ending job, and that is why we work with our members and industry partners to achieve better healthcare outcomes. As such, we are so excited to have an esteemed panel of presenters to walk us through today's presentation on medical respite, and I will give them the opportunity to introduce themselves. I'm going to start with Christine.
Hi, good afternoon, everyone. My name is Christine Haley, and I serve as the Chief Homelessness Officer for the state of Illinois.
Thanks so much. Gabriella?
Hi, this is Gabriella Morelli. I'm the Senior Policy Advisor to our State Medicaid Director at the Illinois Department of Healthcare and Family Services. Thank you.
Thank you. Julia?
Hi, everyone. My name is Julia Dobbins. I'm the Director of Medical Respite at the National Healthcare for the Homeless Council, which also runs the National Institute for Medical Respite Care.
Thank you so much. And Rachel?
Thank you, Jill. Hello, everyone. My name is Rachel Thomas. My pronouns are she and her. I am a Senior Program Manager with the Alliance for Health Equity here at the Illinois Public Health Institute, and I am the Program Lead for the Illinois Medical Respite Capacity Building Initiative.
Thank you all so much. Before we get started, I do want to run through some logistics, bringing your attention to the control panel that should appear on the right-hand side of your screen. This is how you will be interacting with today's webinar. If at any point you have any questions or technical difficulties, please feel free to use the chat box or questions box to communicate with me. Please note that we will be saving time at the end for questions, so please feel free to put any questions you have in the questions box during the presentation, and we'll make sure to address them at the end. And as always, we'll be sending out a post-webinar email that will include materials from today's presentation. And now I'd like to hand it over to Rachel Thomas of the Illinois Public Health Institute to get us started. Rachel?
Apologies, had some difficulties navigating my mute button. Hello, everyone. I actually just want to set the stage for us today. So today we are going to be talking about medical respite across Illinois. I just wanted to review the agenda. So we started off with some welcome and introductions. Next, I'll be passing it over to Christine Haley to chat about the Home Illinois plan. And then I will speak about the Illinois Medical Respite Capacity Building Initiative. Then we'll receive a deep dive on what medical respite is from Julia. And then finally, we'll pass it over to Gabriella to give us an overview of the 1115 Healthcare Transformation Waiver. To finish us off today, as Jill mentioned, we will have a section of about 10 minutes for some questions and answers. So feel free, as she said, to put those in the chat box as we're going or at the end. So at this point, I will pass it over to Christine just to get us kicked off.
Great, thank you very much, Rachel. In September of 2021, Governor Pritzker signed an executive order to fight homelessness, which created infrastructure at the state level to address homelessness. It includes the creation of 3 entities. First, the Office to Prevent and End Homelessness, The second, the Interagency Task Force on Homelessness, which includes the leadership of 17 state agencies, including the directors of the Department of Healthcare and Family Services, Human Services, the Illinois Housing Development Authority, our child welfare agencies, our school system, so the Illinois State Board of Ed and Higher Ed. And the goal of the task force is to be able to implement our plan to prevent and end homelessness, which is called Home Illinois. Home Illinois are the commitments that we have made in state government to address homelessness. And it has a framework with the following pillars. So racial equity is at the core. We know that African Americans are overrepresented within the homeless population, being 14% of Illinois' population, yet 61% of our state's homeless population. The second is around bolstering our safety net, which includes everything from preventing homelessness for those who are at risk of eviction or at risk of losing their homes, to ensuring that we can provide shelter to those who need it. The third pillar is around securing financial stability. So for those who are able to work, being able to provide a pathway for people to access work that pays a living wage to be able to afford rent at market rates. And then for those who are unable to work, to be able to connect folks to both benefits and affordable housing to be able to stay stable in their homes. And the fourth pillar is the one that relates very closely to medical respite, is in closing the mortality gap. We understand from national data that the average age of death of an individual who is experiencing chronic homelessness is in their early 50s. So we have significant work to do in understanding how we bring that death disparity down amongst people experiencing homelessness, and medical respite is part of that work. One of the key activities that we have within the plan is to expand medical respite, and I myself participated in the development of a medical respite program during COVID. So during COVID, I worked for Cook County Health as the director of housing there, and was charged with understanding how we support households experiencing homelessness who were our patients. When the pandemic started, we recognized that there was not a place for folks who had contracted COVID to be able to be in isolation and to be able to recover from COVID within large congregate shelter models. So while at Cook County, we had a partnership with Housing Forward, which is a homeless services agency on the west side in Oak Park, in the western suburbs, to be able to develop medical respite programs and expanded medical respite into suburban Cook County. We recognize at a state level that the level of medical respite that exists is limited, yet it's a needed service, not only for those households experiencing homelessness who have high health concerns and acute health conditions, in addition to those who are being exited from hospital stays. So we are excited about the fact that medical respite continues to be a priority in the governor's budget, that in our FY24 budget, we've included funding for medical respite and have included $1 million increase to our medical respite programming in our proposed FY25 budget. So we are excited about this conversation with you. And excited about the work that the Department of Healthcare and Family Services is doing in their application for their 1115 waiver that is inclusive of the medical respite supports, which we'll hear later from Ms. Maroney about that work. So thank you. I'll pass it back to you, Rachel.
Thank you so much, Christine. And I think that's a perfect segue into speaking today about the Illinois Medical Respite Capacity Building Initiative. But before I dive into that, just wanted to provide some background about the Illinois Public Health Institute. We are a nonprofit organization that mobilizes stakeholders, catalyzes partnerships, and leads action to improve public health systems. Since 2017, IPHI has been working on a variety of projects at the intersection of housing, homelessness, and health, and we have facilitated systems collaborations and development initiatives amongst a number of hospitals across Chicago and Cook County. Beginning in December of 2022, IPHI began partnering with the Illinois Department of Human Services and the Office to Prevent and End Homelessness to lead the Illinois Medical Respite Capacity Building Initiative, which we will chat about right now. So in the first year of the Illinois Medical Respite Capacity Building Initiative, we received funding to provide awards to communities across the state to build capacity for medical respite care in their community. Prior to this award period, there were only 4 existing medical respite programs, most of which were in or near Cook County. So in this first award year, we were hoping to reach a wide geography of different medical respite programs or communities looking to develop medical respite care. So in that award year, we funded 11 communities across 2 tracks. In the first track, it was for communities who did not currently operate a medical respite program, but who needed support for planning to implement one at their site. And then the second track was for those existing programs to conceptualize an innovation or an expansion, whether that be in bed number or in staffing, to bring increased services to their site. Awardees received funding up to $25,000, as well as one-to-one technical assistance from our colleagues at the National Healthcare for the Homeless Council through NIMARC and through learning collaborative meetings. During this first year of the award, we were also able to partner with the Department of Healthcare and Family Services to engage stakeholders for feedback around the proposed medical respite benefit in the 1115 Healthcare Transformation Waiver. We're currently in the second year of this initiative, which is running from July of 2023 through June of 2024. In this current year, we are funding 18 communities across the state to build capacity for medical respite care. This year builds on the last year by, again, providing awards for new planning as well as awards for expansion, but also awards for pilot implementation. So those pilot implementation awards are for communities who participated in planning in the first year, who were able to build a robust implementation plan, and who expect to have some or all of their program components operational by June of this year, so of 2024. Awardees this year are receiving up to $100,000. They're also receiving one-to-one technical assistance and learning collaborative meetings as well. On the screen, you can see a list of our awardees, and then to the right, you can see a map of where they're located across the state. While we do still have quite a few awardees within Cook County, you'll also see that we have some geographic diversity here, whether that is in Madison County or near Springfield and Sangamon County, in Rock Island. We have quite a bit of diversity across the state. I also just wanted to highlight how medical respite has grown across these 3 years. So as I mentioned, when we started, there were 4 medical respite providers active, only across 2 counties, and there were only 72 beds available statewide. However, by the end of this project year, so in June of 2024, we anticipate that there will be 12 active medical respite providers across 6 counties, and that the number of beds will rise to 188. So we have seen some pretty rapid growth, both through this initiative and outside, with the increased attention and support for medical respite and investment that we've seen across the state, which we're really excited about. In addition to the Medical Respite Capacity Building Awards, the Illinois Medical Respite Capacity Building Initiative has several other components, 2 of which are system building components. So the statewide Medical Respite Collaborative and the Cook County Medical Respite Network both work regionally to develop systems to support providers. Specifically within Cook County, they're working on developing a referral tool and a network guide to help align systems across the region. We're also going to produce a gap analysis to highlight needs for further investment and further research and expansion in medical respite care across the state. And then we'll also be doing a communications campaign to raise awareness of medical respite care across the state. And then we'll also be doing some stakeholder engagement around the 1115 healthcare transformation waiver as we work with our colleagues at HFS. And Gabriella will speak a bit more about the waiver towards the end of this presentation. But now that I've given this intro into what we are doing and building in Illinois around medical respite, I want to turn it over to my colleague Julia, just to provide a deep dive into what medical respite care is.
Awesome. Thank you so much, Rachel. You can go ahead and go to the next slide. So like I said earlier, my name is Julia Dobbins and I work for the National Healthcare for the Homeless Council, and the council has been doing work in medical respite care since the first medical respite care programs opened in the 1980s. And actually the first convening of medical respite providers happened in the year 2000 in Chicago. And that was where we developed the Respite Care Providers Network. And so we have been doing work in medical respite since then. And in the summer of 2020, we launched the National Institute for Medical Respite Care, or NIMARC. And that's really given us an opportunity to do more than just ground up support for communities as they're building their respite services. That's really given us an opportunity to work with communities and systems on how they integrate medical respite services. And what's happening in Illinois is pretty innovative and has really rapidly increased capacity for medical respite programs across the state. We're really excited about it. Next slide, please. So I assume that you're at this webinar because you know a little bit about medical respite care or you're interested in medical respite. So I'm assuming most folks know what medical respite care is. But just to get us all on the same page, we define medical respite care as short-term care for people experiencing homelessness who are too ill or frail to recover from an illness or injury on the street or in shelter, but who don't require hospital level care. So it is short-term residential care that allows folks the opportunity to rest and to recover in a safe environment while also accessing wraparound services and some clinical support. For the purposes of our conversation, we're using the term medical respite. That's what we use nationally, but there are a lot of communities that use the language recuperative care. It really is a regionalism more than anything else, but I just want to be clear that recuperative care and medical respite care can be used interchangeably. They describe the same service. But there is a lot of diversity in what a program can look like. This is a real strength, we think, for medical respite care, that medical respite programs really reflect the needs and resources of their specific communities. So there's diversity in what the bed number can be, what facility it's housed in, their length of stay, how they are staffed, and even what their admission criteria might be. Next slide, please. So when you're thinking about where medical respite fits within this continuum of healthcare, it really falls more on the left side here. The original idea with when medical respite was created was that this was supposed to be a resource for folks who would be discharged home if they had a home to be discharged to. So the idea is we want this service to be community-based, and it's not intended to be an institutional setting. It is short-term. Most medical respite programs are less than 90 days. And it really is an opportunity to engage with some healthcare oversight, but we're wanting people to really build their independence and their self-management skills while they're in medical respite as well. Next slide, please. So like I said, there's a lot of diversity in medical respite, but there are 4 primary components that we look for in all programs. First is this clinical care piece. So it is typically an acute clinical event that brings somebody into a medical respite program, and often it is the resolution of that event that determines their length of stay in the program. Now, what clinical care looks like in that medical respite program really depends. So it could be a program that doesn't have any clinical care on site, but they have a partnership with a health center, and so they're providing transportation to the health center. Maybe it's a shelter and a mobile medical unit is coming to the shelter a couple times a week. Maybe the medical respite program has a part-time nurse who's able to do vitals and help with some wound care and maybe help with some medication support. It really just depends, but across the board, it really is a clinical issue that's bringing somebody into medical respite. Now, that being said, that is the primary focus, but case management is right behind it. We know that when people come into medical respite, they're not just coming in with a broken arm or recovering from pneumonia. They're also managing all of the challenges that come with experiencing homelessness. So part of the goal while they're in medical respite is also to get them connected with services and resources and anything for which they qualify. That includes getting folks connected into primary care. If they're not already connected to a primary care provider, we really want to focus on that long term. We want people to have a healthcare home. We don't want people cycling in and out of the emergency room if it's not an emergent issue. And then finally, like I said earlier, this self-management support piece is really important. This might be the first time in a while you have somebody for 60 or 90 days and they're starting to feel better, they're eating consistently, they're sleeping 8 hours a night. This is a great time to start practicing using a new mobility device or practicing taking their meds independently, or work on getting an ID or reconnecting with a friend or family. We want folks to leave the medical respite program a little bit better able to self-manage than when they came in. That's part of the focus. And then across the board, we see that medical respite programs have to provide 24-hour access to a bed, 3 meals a day, help coordinate transportation, safe space for storing personal items, access to a phone, and then some type of wellness check every 24 hours is best practice, but wellness checks certainly don't have to be done by a clinical provider. Next slide, please. So a great resource that I recommend people check out are the national standards for medical respite care. Like I said, the first convening of respite providers happened in the year 2000, and that led to the creation of the Respite Care Providers Network in 2004. We're celebrating our 20th anniversary this year. And the Respite Care Providers Network decided to create standards of practice for medical respite programs. Because yes, there's a lot of diversity. We want that diversity, creativity, innovation, but we also want to ensure quality. We're talking about folks who are very vulnerable, and we want to make sure that we're clear on what a medical respite program is and what they should be providing. So they wrote standards for medical respite programs that are available on the NIMARC website, and I think these standards are just a great framework for understanding how programs operate. What I will say about the standards is very few programs meet 100% of the criteria perfectly right when they open their doors, and that's okay. Best practice is to start somewhere and move towards high fidelity to the standards, but it really is intended to be a quality improvement tool. Next slide. Like I was mentioning around the core components of medical respite care, the clinical care piece, we were discovering that it was hard for people to really understand the differences in medical respite programs. Like I said, there are some programs that might not have any clinical services, and then there are some programs that have really robust clinical services. So we created the different models of medical respite care as a way for our community to better understand what medical respite care can look like. So these models were built based on the work that we've done with the 150 to 160 programs across the country. So really these models of care, what they are describing is the level of clinical services provided within the program. So it's outlining what level of acuity programs are able to address safely within their 4 walls. So any of these models of care could be shelter-based, any of them could be in a standalone facility. Staffing might be different, but when it comes to what clinical services they're able to provide, that's the difference between these 4 models. So for coordinated care, that really is a focus on comprehensive case management and care coordination. So this might be a 3 to 5 bed program that is based in a shelter. It's a community health worker, case manager, maybe a social worker. And really what they're doing is providing the safe space for somebody to be 24 hours after an acute event. That might be a good place for home health to come in and provide services. And they're making sure they're coordinating all of the needs related to their clinical and social needs. And then if you go all the way up to comprehensive clinical care, these are programs that are able to do more robust clinical services. So they might be able to manage really complex wound care. They might be able to do IV medications for people who need like 6 weeks of IV meds. They might be able to take folks who are really struggling through chemo and needing more support. They might be able to also do folks who are managing more complex behavioral health needs. So again, there's a lot of diversity in the clinical side of this. We highly encourage programs when they can to partner with community health centers, with FQHCs, and with healthcare for the homeless clinics. We just think that's a really solid partnership for medical respite programming. Next slide, Rachel. So just to give you a quick snapshot of what medical respite looks like currently across the country, this data is, we update the state of the field once a year in May 2023, and this data is already a little bit outdated because programs are just growing so rapidly, and I'm so excited that our Illinois data is going to explode this year. It's so awesome. But just to give you a sense, the average number of medical respite beds in a program is around 17. We generally see programs between 5 and 20 beds. Certainly there are outliers. There are some programs in California that have well over 200 beds. And in terms of location, like I said, there's a lot of flexibility in where you can house your medical respite beds. We see a lot of programs, that 42.5% is shelter-based. A lot of programs start in shelter. Some stay in shelter, but a lot of programs at least start in shelter. It's a really good partnership, and it's an affordable way to launch your program. The next largest in the green right there, 28%, is a standalone facility. Next slide, please. In terms of staffing for medical respite programs, I think it's no shock that we see a lot of nurses, social workers, and case managers. These are folks who can wear multiple hats. So people who are doing the intake, also providing the care. Also, we see a lot of nurses and social workers doing budgeting and all of those pieces within programming. We all know how nonprofit work works. But we're seeing some growth that's pretty exciting around more occupational therapists, more community health workers, and more peer support within medical respite. And that is something we're really excited about. So folks with the lived experience and expertise of homelessness becoming staff of medical respite programs. And then for the average length of stay, generally, I would say 31 to 45 days is what we're seeing. That number is starting to go up as more states are looking at Medicaid reimbursement for medical respite and extending that time frame, which is really exciting. I think the longer of a runway folks have in medical respite, the more opportunity you have to make some really meaningful change. Next slide, please. In terms of medical profiles for persons within medical respite spaces, what we see often is chronic illness that is not treated or managed well, so issues become acute. So cardiovascular disease, diabetes, HIV, skin conditions, respiratory issues, we see a lot of that. Also a lot of post-operative care, and wound care, but we're seeing more and more substance use disorders and behavioral health challenges. That's a part of the reality of serving folks experiencing homelessness. Many folks are managing many co-occurring disorders, and so medical respite programs have to be prepared to take on the whole person when they come into the medical respite space. Next slide, please. For funding, this is another slide that is going to be changing in a couple of months. So still across the country, what we're seeing more than anything is medical respite programs having a primary funding relationship with a hospital partner. Most medical respite programs are receiving referrals from a hospital partner. And so those hospital partners are providing funding either on an annual grant basis, a monthly basis, a per client basis. There's some type of funding structure between the hospital and the medical respite program. What we're seeing our largest growth here for funding is around Medicaid and Medicaid managed care. There are now 14 states that are moving forward with reimbursement for medical respite programs, and this is really a potential opportunity for sustainable funding for programs. We are, with Medicaid reimbursement comes all of the benefits and some of the administrative challenges. So there are costs related to that for some programs as well. So I think there will always be a need for a couple of different funding lines for medical respite programs. And those hospital relationships are so central to the operations of medical respite care. So even as Medicaid is coming on board, I think continuing those hospital relationships is really, really going to be important. Next slide. So what does the literature say about medical respite care? I think it's probably no surprise there's not enough in the literature yet. We do have a literature review from 2010 to 2020 that I'll share in the chat, but what the literature is saying is that medical respite care can have an impact on readmission rates. So decreased readmission rates for people who had medical respite as a discharge option compared with folks who did not have medical respite care as a discharge option. Also, we're seeing folks are utilizing healthcare services more after connected to a medical respite program. And that's a good thing. We want people to come into medical respite care and start seeing their primary care provider for preventive and primary care. We see that as a really positive result. And we see that medical respite care can result in some cost savings for hospitals. I think we have to be careful with that. There are always going to be folks who come into medical respite. They haven't really engaged with healthcare in a while. They might be diagnosed with stage 4 lung cancer, and so their costs are not necessarily going to go down because of their medical respite stay, but there are always going to be outliers, I would say. But if readmission rates are decreased, there can be a significant cost savings for hospitals. Next slide, please. So the last thing I want to highlight, and this is something I think is a real benefit of medical respite care, is that medical respite programs often serve as like a community hub for other organizations that are interacting with people experiencing homelessness. Medical respite programs have to be experts on what resources are available in their communities, and they have to develop relationships with all of these resources. So there's room at the table for a lot of folks when it comes to starting and operating and expanding medical respite care. So we see medical respite programs working with folks with lived expertise, obviously working with hospitals and other homeless service providers. It's important for respite programs to be in partnership with the local continuum of care, so we can think about how to connect medical respite clients with housing while they're in medical respite. Certainly government entities, FQHCs, substance use treatment facilities, some are really working closely with VA services, housing providers, and we also are seeing some local universities and local law enforcement supporting medical respite as well. Okay, I think that is all of my slides. So I'm going to pass it over to Gabriella to tell us a little bit more about the 1115 waiver.
Thank you so much. Can you guys hear me okay?
Yes.
Oh, good. Very, very good. Hi, everybody. This is Gabriella Maroney from the Illinois Department of Healthcare and Family Services, and I'm very happy to be included in the presentation today to talk about how we hope and intend to bring medical respite into the Medicaid landscape. As most of the folks on this webinar know, our vision for the future really is focused on addressing the social and structural determinants of health and making equity the foundation of everything that we do. And our 1115 request to amend and extend our transformation waiver by addressing health-related social needs is squarely rooted in this vision for the future. We're very excited for the opportunities to bring medical respite services and a whole host of other health-related social needs benefits into the Medicaid enterprise. Next slide, please. So just kind of a quick background on 1115 for those of you for whom it's helpful. Waivers under Section 1115 of the Social Security Act provide expenditure authority for state Medicaid programs to demonstrate the impact of something new, some kind of service or flexibility or innovation that otherwise wouldn't be allowed under traditional Medicaid rules. And so that's what that's how we hope to demonstrate the value of medical respite within the Medicaid service delivery landscape. Next slide, please. So a couple of fundamentals. We're really hoping to secure two things with our request for coverage for health-related social needs generally and medical respite specifically. One is to get the approval that would allow the addition of this new service, as well as approval to target the new services to certain designated pilot initiatives. Here, working with our existing medical respite providers in Illinois, as well as new providers that have already been identified, and maybe some that will come to the table at a later date to demonstrate the impact of having this really important service. And then we're also seeking the funding that will allow the state to offset its investments by bringing in federal match for these services. Next slide, please. A little bit more background and context. We received approval in 2018 for what was then called the Behavioral Health Transformation Waiver. That approval was secured under a previous gubernatorial administration, and I apologize for not updating my slide. It did expire in June of last year. And so we submitted a request to extend and significantly amend that authority to cover a whole range of health-related social needs benefits. And we proposed to rename the demonstration. So moving away from behavioral health exclusive focus and onto the broader healthcare transformation goals. So the new name is the Illinois Healthcare Transformation Section 1115 demonstration, which I think you'll agree really rolls right off the tongue. Next slide, please. So what we're really trying to do here is demonstrate and learn more about what we instinctively know to be true, which is that unmet health-related social needs, needs that are driven by those social determinants of health, are connected to worse health outcomes for Medicaid members and drive higher healthcare spending. Policy guidance that federal CMS has offered in this presidential administration acknowledges this link and provides an opportunity for states to secure federal approval and match for investments in health-related social needs services and infrastructure. Next slide, please. And so we've asked for federal approval to add these new HRSN services that target the social determinants of health. We are also asking them to sustain some existing pilots. I'm sorry, guys. Let me start this bullet over again. We're asking for authority to sustain some of our existing pilots and add some new demonstration pilots to test the value of really working with Medicaid members in new ways that are aligned with many of the social needs and context of our communities. Next slide, please. So some of you have seen this slide before. We are seeking approval for a wide variety of health-related social needs focused benefits. And we're obviously gathered here today to talk about medical respite. Medical respite, along with housing supports, are really focused on individuals who are at risk of or experiencing homelessness. And they are part of the commitment that the Department of Healthcare and Family Services has made to Home Illinois, the plan to prevent and end homelessness. And as such, they are top priority for our department as we are planning to implement a whole host of HRS and targeted benefits. We are also planning to fast track implementation for community reintegration for individuals who are transitioning out of incarceration and returning to the community. We also have included requests in our application to begin piloting coverage for food and nutrition services, for employment assistance, for non-medical transportation, and for violence prevention initiatives. Next slide, please. So I think it's really important for this group. Most of you probably already understand this, but I want to emphasize that we intend to lean into our managed care infrastructure to administer these HRSN benefits. So eligibility will be tied to individuals who are Medicaid eligible and enrolled in a Medicaid managed care plan, which accounts for the vast majority of our Medicaid population in 2024. Eligibility for specific benefits is tied to both clinical and social criteria. That's required by federal CMS guidance, and that's consistent with how other states have secured federal approval to pilot HRSN benefits. We have taken a really broad and inclusive approach to how we establish those clinical and social criteria. There's a lot of information available about the proposed benefits and eligibility on the HFS website. Next slide, please. So focusing on the medical respite benefit, individuals enrolled in managed care who are experiencing homelessness or who are at risk for homelessness and either are at risk for going to the emergency department or being hospitalized or institutionalized, or who are currently in the hospital or institutional care or in the emergency department. Next slide, please. So the proposed benefit is broad and has been informed by the other folks that you have heard speaking today. We are seeking authority to offer this benefit for up to 6 months at a time. And we're proposing that it include specialized on-site case management, connections to other health-related services and other HRSN benefits that the individual may be eligible for. Transition support to come into medical respite care and to leave medical respite care. It also includes limited support for ADLs or IADLs, as well as monitoring ongoing medical or behavioral health conditions like vital signs, assessments, wound care, medication monitoring, etc. Next slide, please. So we also recognize that the population of individuals who will be eligible for medical respite are also, by virtue of the fact that they are experiencing or at risk of homelessness, we're going to want to get them connected to the housing support benefit, for which we are also seeking federal approval. Again, this will follow the same Medicaid population eligibility. And our needs criteria, as I mentioned earlier, were set broadly in order to bring as many resources to bear on this particularly vulnerable population enrolled in the Medicaid program. So they're experiencing homelessness or at risk of it, or institutional placement. We also want to make sure that individuals who are leaving violent or dangerous situations can avail themselves of this benefit. The medical or the health-related criteria for this benefit, again, are defined broadly. They only need to meet one of these, which is high utilization of emergency department, hospital, or crisis services, having been determined to be high risk or high cost based on their service utilization or healthcare history. And I know we're getting to the point where we want to get to Q&A, so I'm not going to, sort of go through this in great detail, but you can see that it's a broad set of eligibility criteria, and you can read this in detail on the HFS website. Simply go to our homepage, look for the 1115 button, select the 1115 transformation button, and you can go look at the proposed benefits. Next slide. We have some principles that are guiding our implementation planning work. We want to make sure that Medicaid members, while they must be enrolled in managed care to be eligible, we do want them to have multiple pathways into these services. We are hoping to use federal approval to allow further investment in our healthcare transformation collaboratives and in the Home Illinois Initiative, and also to really support our existing and nascent medical respite programs. We want to find really effective, streamlined, straightforward ways to bring these non-traditional community-based providers into the Medicaid program, into our Medicaid enterprise. And we are really going to be looking to our Medicaid managed care plans to help us do this in a way that is mindful of the tremendous contributions that these providers have been making to our Medicaid members for a long time before we ever brought 1115 authority into the picture. So I'm thinking that this might be a good place to stop, even if there are more slides, in order to get to some of your questions. Does that sound right? Right?
Absolutely. Thank you so much, Gabriella. I think you got through a majority of the content. So right now we can open it up to questions.
Thank you all so much. Just a reminder, if you do have questions, you can enter those into the questions box, and I can see those and can read those to the panelists. I think you guys did such a great job. We don't have any right now. So while we're waiting for those, I just wanted to say thank you. I think this is such a great, innovative approach to build the capacity to have HFS and DHS work together to really build that capacity for these services while we wait for that approval from CMS for the 1115 waiver. I did get a question about whether, I think Julia, you had mentioned that this program was in other states. Potentially 14 other states are looking at it. Do you have a sense of which ones are currently up and running at this point? I think you mentioned California.
Yeah, I'd be happy to share that. And there is a resource on our NIMARC website that is like a state of the states as it relates to Medicaid. And maybe I can share that in the chat as well. But California was the first state to move forward with medical respite as a reimbursable service through Waiver. And that went into effect in January of 2022. The next state right behind them was Washington State. And believe it or not, North Carolina has also moved forward. So those are the 3 states that are now operating with medical respite as a reimbursable service. And there are several states that are coming online. So Illinois, Minnesota, New York are the 3 that should be coming online in the next year. And then there are several states that are exploring ways to pursue an 1115 waiver or a statewide amendment or something through the legislature. So Colorado is looking at that, Nebraska. Yeah, it's pretty exciting. And I think the 1115 waiver is really a good opportunity for other states to look at funding for medical respite care. I think in California, I just want to add briefly, the goal is for medical respite to become a benefit of Medicaid. But the challenges there is we have to have enough medical respite programs across the state so that the resources available to all Medicaid folks. So they're working to build up their capacity. And I think, like I've already said, Illinois is already a step ahead of a lot of other states in their investment in the capacity of this resource statewide.
Great, thank you. Yeah, and I think from a health plan perspective, a lot of them participate in other states as well. So I think that might give us, some ideas of who to reach out to in other states from a health plan perspective to see how it's working and just get a little insight there. We do have a question. Can you show the slide with the list of panelists? Again, I think there was some question about names of presenters. And we're going to be sending this out afterwards as well. So you'll get the full deck. Let's see. There's a question about how you can get enrolled in the respite care program as a provider. So if someone is interested in becoming a provider or is already a provider and learning more about what's happening in Illinois, who should they contact? Is that you, Rachel?
Yes, definitely get in contact with me, and in a moment I'll change the slide back to the final slide with my email, and I'll also pop it into the chat so you can connect with me. But yes, please do reach out if you're interested in exploring developing medical respite further or getting involved with currently active or currently developing medical respite programs. I'll also add that the Illinois Medical Respite Capacity Building Initiative intends to provide regular updates through the I'm HIP newsletter, just letting folks know when new programs are coming online or other developments in the landscape of medical respite across Illinois. We'll likely also be sending out some physical resources for folks to understand and learn more about the landscape of medical respite across the state. So if you're interested in that, please definitely pay close attention to that newsletter, and also feel free to get in contact with me via email. Thank you.
Thanks, Rachel. Yeah, before we wrap things up, we do have one more specific question. Will medical respite consider refugee population, and within that population, minors with complex medical care needs? I'm not sure if that's for you, Gabriella, or a general comment for Julia.
I'm happy to take a stab at it. I'm going to let Julia speak to sort of how this particular service and setting may serve folks with complex clinical needs. But I'm happy to describe the eligibility for the benefit will be restricted to individuals who are enrolled in Illinois' medical assistance programs under Medicaid authority. And so if it's a population that is funded only by the state, it's a state-only population, that will not be an individual, unfortunately, who will be eligible for this service.
Yeah. So what I will just add to that, I think this is the importance of the funding options for medical respite programs. So there are programs that will take folks who are undocumented, but they are not covered, obviously, with insurance. So that is something that programs have to figure out what their funding structure is and just what their admission criteria are. But there are programs that are set up to take folks who are undocumented. I think the more complex piece, honestly, is minors or dependents who might need clinical support. We are seeing an increase in medical respite programs for families experiencing homelessness. So either parents who have dependent children who are needing some medical support, or families whose children are needing post-acute care. Those are few and far between across the country. I think I know of 3 or 4 programs that do that. But I think that's a really interesting thing for this, for us to hear and consider in the capacity building across Illinois, those needs for folks, for families experiencing homelessness for medical respite care.
Thank you. Thank you both. I think that's all of the questions that we have in the chat. I do just want to say thank you to all of the presenters today. I think this was a great sort of intro to medical respite. And I know there's a lot of work to be done, especially when we think about implementation and working through all of that in terms of it becoming a bona fide Medicaid benefit, and also how it interacts with all of those other services you mentioned, Gabriella, in the 1115, and sort of setting up a system, a care coordination system along with that as well. So thank you all again. Would welcome you all back to present once the 1115 is approved, and provide a status update, and look forward to working with all of you from an implementation perspective as well. All right, that concludes the webinar today. Just a reminder, we will send out the slides to everyone who registered. So thank you all for attending, and we'll see you at the next one. Thank you.
Thank you.
Thanks so much.